So we are going to, I would say, to implement the first panel, which is about setting the scene from different angles from EU and international initiatives on healthcare in rural areas. So we have Christoph Spegele from DG SANTE, John Wynne-Jones from EURIPA, past president of EURIPA, and Theadora, Koller, and Chris Brown from the World Health Organization. So I will give you the floor one by one. If we have time to collect some questions from the audience, we will do. Otherwise, we will move to the other session. But let's see how it goes. So first of all, Christoph, I give you the floor for addressing medical deserts under the third health program and other policy and funding mechanisms to improve accessibility of healthcare in rural areas. So you have the floor, Christoph.
Yeah, thank you very much. Thank you very much for inviting me. Good morning, everyone. Could you maybe, yeah, excellent. There comes my slides. Could we directly go to the first topical slide? Yeah, exactly. Yeah, I'm actually, I think this Slido was a very good introduction for my presentation because I'm going to focus on the health workforce, and indeed I think the health workforce is a crucial aspect for access to healthcare in rural areas. I would like to start with some statistics. Here you see the numbers of nurses and doctors per thousand population amongst the EU countries. And on average, we have 8.4 nurses per thousand inhabitants and 3.9 doctors in the EU. But I would like to say that there are big differences between the member states. So if you look at the data from the countries, then you see that the number of practicing doctors ranges from 2.4 in Poland to 5.3 in Austria. So that's more than double. And the number of practicing nurses varies by the factor of 4, from 4.4 in Bulgaria to 17.9 in Norway per thousand population. So we have Norway in there too. And also the nurses to physician ratio is there's a quite large difference, spanning from 1.1 to 1 in Bulgaria to more than 4.4 to 1 in Finland. So I think that is a big challenge, that you have a very diverse picture when it comes to the numbers of health workers, also to different groups of health workers. And now coming back more to our seminar today, there are of course also within member states huge differences in the availability of health workforce. Usually we find, of course, a higher density of health professionals and especially doctors in more urban and wealthier areas and capital regions than in less affluent ones or in remote or rural areas, which is, of course, a big challenge in these areas. Could we have the next slide, please? In my unit, we work on the state of health in the EU report. That is a biannual cycle that takes a deep look at the health systems, including health workforce in the different member states. This is done by the Commission and by the OECD jointly. And there, from the last companion report of the state of health in the EU report, there are three main takeaways. And one of the main points of this report covered the health workforce. And the strategies going forward to improve the differences in health workforce deployment or availability, and also to resolve or to tackle shortages are three main points. We need to implement a better health workforce planning. We need to increase the investment in training and education, and we need to equip the health workforce with new skills and make skill mix innovations available. For example, task shifting for a more efficient provision of healthcare. Could I have the next slide, please? And that leads me directly to DG SANTE's or my unit's actions on health workforce. As I said, I think shortages in skills and in workers are our main challenges at the moment, not only in rural areas, but especially in remote and rural areas. And I brought with me today 4 actions which I would like to present to you. Of course, there are also more amongst DG SANTE, but these are the ones which fall into the remit of my unit. The first is a cluster of 5 projects funded under the 3rd health program. They focus on medical deserts, on workforce retention, and on task shifting. So these are 3 really crucial points, and I think these are projects which run from 2021 to 2024, so they will soon come to an end. But I think these are topics that we can still have to build on also, and that one can take also forward, of course. I'm very glad when I look into the agenda, that 2 projects are represented today in the workshop, AHEAD and OASIS. So I won't go into much detail on this, but I would like to stress that is a really, it's crucial work. Medical deserts, which are areas of extreme undersupply of health services, and that is a typical problem in remote and rural areas, or also border areas. Then health workforce retention. That is the issue of many health workers leaving the sector. So we have to also retain the workforce that we have, not only inspire new workers to join the sector, but also we have to retain the workforce that we have. And the third point, which I spoke already about, task shifting, that are new tools, practices, how to optimize the division of tasks between different health professionals. The next project which we are funding, please go back. Thank you. The next project which we are funding is the Joint Action Heroes. That is a joint action with the member states, EU member states, on health workforce planning and forecasting. I think that is also one of the key points that I mentioned on the slide before as a takeaway from the research done in the State of Health in the EU report. We need to have better health workforce planning and forecasting. So we need to forecast the demand of health workers in the different member states, in the different regions, and we need to also forecast which skills are needed. And these 2 points, the number of health workforce and the skills forecasting and planning, that are 2 crucial things. And this joint action works on 3 main clusters. First of all, to improve databases used in health workforce planning, because of course data is the basis for any planning process. The second is to develop effective tools and methods to carry out health workforce planning. And the third is to define the best skill mix needed by professionals to carry out health workforce planning. So in this joint action, they will design a roadmap and carry out implementation strategy to equip member states with more capacities to do effective health workforce planning. The third important project that is within the remit of my unit at the moment is the Be Well Blueprint Alliance for a Future Health Workforce Strategy on Digital and Green Skills. That is a large-scale partnership with stakeholders from the whole health ecosystem, which features under the umbrella of the Pact for Skills. The Pact for Skills is a shared engagement where the data are coming from. There's a source for the data. It's from the country health profiles. It's from the OECD and Eurostat. I don't know. Well, we'll address that then later in the Q&A. So this skills strategy, the skills partnership will develop a strategy which will be a framework for the modernization of curricula in medical professions, and will identify what we will what we will need in the future in terms of especially digital and green skills. So this will not be a reform initiative, but it will be a strategy that will give the whole health ecosystem the tools on the hand to react to the twin digital and green transition and make health systems future-proof. Also, this project will run pilot training courses focusing on digital and green skills. The third one is the most recent. The fourth one is the most recent initiatives that we run. Is a training initiative funded under the EU for Health program with a focus on digital skills. These projects, which are funded under the EU for Health program, have kicked off in 2023. It is 7 projects, and they cover key areas of importance, such as antimicrobial resistance, oncology, gynecological surgery, and digital skills, of course, more advanced digital skills. Each project has modules for nurses, GP specialists, and also, which I think is important, non-clinical staff. And now the last slide, please. The last point I wanted to present to you, because I think we're running out of time, is the Recovery and Resilience Facility. This huge funding program with 720 billion euros budget is also funding health projects with a focus on improving access to healthcare and also with a focus on health workforce. So you see a little overview of some projects that are not all projects, because all member states have requested funding for health reforms and investments under the Recovery and Resilience Facilities, but these are a few very relevant ones. Maybe with a view to rural areas, I can point out the projects in Bulgaria, for example. They have a reform and a major investment in improving outpatient care across the country with focus on underserved areas, and also investment and reform on healthcare workers to attract them to remote and underserved areas. Maybe also to mention Austria, they have a major investment in improving primary care, which means upgrading and building new primary care healthcare centers together with a reform to improve the provision of primary care. So, and now I think I'm out of time. Thank you very much for having me, and now I'm looking forward to the rest of the seminar. Thank you.
Thank you very much, Christoph, for this overview of the disparity between member states in terms of number of workers, also profiles of workers, and also this overview of EU actions to try to, I would say, to fill these gaps in terms of quantity, but also in terms of quality, if I understood well, and also this point on the Recovery and Resilience Facility applied to health. So thank you very much. So now I propose to move to John Juan Jones from EURIPA to present the blueprint for rural practice in Europe. You have the floor, John.
Thank you very much. Could we just have the opening slide? We got an opening slide? Great, thank you. That's not my slides.
Do not hesitate to make it shorter if possible, because we are running out of time. But
thank you. I'll stick to my allotted time of 8 minutes. So, good morning. My name's John Wynn Jones. I was a full-time rural family doctor in Wales for over 30 years until I retired. And I really believe that this gives me credibility. I know what it's like. I've worked on in a small rural community. I'm the immediate past chair of the rural group of the World Organization of Family Doctors. And I currently work in 2 universities in the United Kingdom with a remit for rural and global healthcare. I co-founded the European Rural and Isolated Practitioners Association, which is the long term for EURIPA, with my colleague Jane Randall-Smith in 1997. And I'm still proud and honored to remain part of that. My remit today is associated with the health workforce and how it contributes to enhancing access to rural healthcare. We established EURIPA because we met colleagues working across rural Europe who shared a concern about the state of rural healthcare, and in particularly rural primary healthcare across the whole of the continent. Sadly, despite the fact that we've been vocal about the well-being of Europe's rural communities, progress has been slow and rural healthcare remains at significant risk. Can I have slide number 2, please? In 1938, Andreas Stamper, one of the most prominent public health experts of the 20th century, and the founding father of the World Health Organization and the World Health Assembly, wrote a paper in the New England Journal of Medicine. Can I have slide number 3, please? And I enclose some of the quotes from this paper where he described the lack of rural health workers and argues that specific changes are needed in the educational system to prepare them for the challenges that they will encounter and the wider range of skills that they will need. Sadly, this has not changed greatly since this groundbreaking paper. Policymakers and educational establishments still rely on producing generic health workers with limited preparation for the context that they're going to work in eventually. One size does not fit all. In a paper entitled The Primary Care Workforce in Europe, a cross-sectional international comparison of rural and urban areas and changes between 1993 and 2011, published in the European Journal of Public Health in 2020. Slide number 4, please. The authors stated clearly that rural areas have significant problems in attracting and retaining a primary health workforce. Family doctors work more hours and provide more medical procedures to their patients. The rural workforce is aging with mounting concerns about the future recruitment and retention. They concluded that dedicated human resource policies for rural areas are required with a view to an aging GP population, to the individual preferences and needs of those GPs, and to the decreasing attractiveness of rural areas. Slide number 5, please. A parliamentary inquiry into rural health in England, published in 2021, which I was involved in, stated that workforce issues are the biggest challenge. Person-centered planning and delivery is the antidote. It went on to say that radical and disruptive approaches, which put more emphasis on primary care, multi-agency working, and community ownership in an environment which accommodates at least some appetite for risk, are important. The growing concept of medical deserts in Europe, slide number 6, please. I just make it clear, I don't like the term medical deserts. It makes it very medically orientated as opposed to healthcare. And it was first described in France, has to some extent focused politicians and policymakers on the possible impending implosion of rural health in rich countries with sophisticated health systems. And we're beginning to see similarities in these rich, sophisticated systems that we see in low and middle income countries. May in the future, these areas may have difficulty in accessing universal healthcare. I could quote much more, as well as recount stories that I hear from colleagues, and these are GPs, nurses, weighed down by intolerable workloads. But it gives an insight into the origins of our blueprint for European rural practice, which replaces the original charter that we wrote in 1997. Slide number 7, please. Europe has a substantial rural population, varying from country to country. The overall population accounts for 28–30% of the population. Yet, according to the EU Commission in the 2023 Rural Vision Report, the number of doctors currently working in rural areas has dropped to 24% of the medical workforce. Now, we conducted a survey in EURIPA, and we could find little in the way of identifying national policies, networks, and educational and training pathways across Europe with particular focus on rural. The survey concluded that as the number of health workers in rural areas has declined, the demand for these services has increased substantially due to issues such as an aging rural population, failure to invest in primary care, and fewer available resources. I commend you all to read the blueprint. It's really important. Many of the things that you've already mentioned today are in it. Slide number 8, please. It aims to provide a vision for rural care in Europe over the next 25 years. The blueprint aims to ensure that rural communities have access to high quality, safe and effective healthcare, irrespective of where they live. And it's not just about telemedicine. You know, you deserve the same standard if you live in rural as you live in an urban environment. It defines and it describes rural practice in the European context, with a family medicine at its heart. It outlines the nature of rural general practice, including extended roles and scope, public health, community engagement, occupational health, and most important, generalism. Finally, it looks to the future challenges. Slide number 9, please. When we talk of workforce, we must see it in the spirit of Alma Ata and the Astana Declaration as multi-professional, cross-sectoral, and community engaged. The blueprint emphasizes the importance of 3 elements contributing to improved recruitment and retention, and these are gathered from Australian and North American evidence. First of all, choose students from rural backgrounds, not just the brightest students in the country, but ones from rural backgrounds. We say this is growing your own. Provide extended rural placements during the undergraduate period. And finally, establish special targeted rural postgraduate training programs. In addition, the blueprint emphasizes the importance of team working, leadership, mentorship, and support, especially for younger doctors and nurses, but also for older ones nearing retirement. It talks about digital technology, telehealth, about emergency care, mental health, and much more. Finally, it emphasizes the importance of building a research base and a rural academic infrastructure to bridge the evidence gap, which is clearly missing between urban and rural data. Now, recent papers from France and Catalonia, and I've added those to the list of references, so please have a look at them, have shown that they've added credence to that this is also the case in Europe. There's much more that I could do, but time is short. And I will finish with our mission statement. And that's, we need to build and establish a workforce that is fit for purpose. Slide number 10, please. This is just a list of some of the references that I've alluded to. My plea to you all today is, look, here is a model, here is a plan. And I really want you to listen to your workforce. We don't necessarily want just necessarily a top-down approach. We need the workforce themselves to contribute to the solution. Thank you very much.
Thank you very much, John, for this very interesting, I would say, testimony and also the proposal of the blueprint. And you have underlined clearly the tension between the number of workers declining and also the increased needs in terms of healthcare to be developed in the rural areas, and also other issues in terms of facilities, long waiting times, high cost of services. So a lot of issues, challenges that we will be, I would say, able to discuss later during the day. So many thanks for your intervention. And now I will give you the floor to the World Health Organization speakers, Theadora, Koller, and Chris Brown. You have the floor.
Dylan, thank you so much. It's a pleasure to be with you all today. If we could please have the slides. Thank you. So yes, I'm Theadora Koller. I'm Senior Technical Lead for Health Equity in the Department for Gender Equity and Human Rights in WHO headquarters. And I'll be presenting today with Chris Brown, who's head of the WHO European Office for Investment for Health and Development that has a very strong focus on well-being. Next slide, please. So I'd like to start with a bit of an overview of WHO work globally on rural health equity. We focused quite a lot on primary healthcare-oriented health systems strengthening through particular investments in areas such as the health workforce, as we've been discussing, and digital health. And in the slides that come, we'll share a bit of the work there. We also focus on monitoring health inequalities. This is particularly important for integrating a rural focus in policies. We have HEAT, which is a tool that can be used by national policymakers, and they can download their data sets and then see the rural-urban differences and also differences by different equity stratifiers. We map barriers to health services. We have different methods for that and work with countries in doing that. Barriers in terms of availability, accessibility, acceptability, and effective coverage of health services in rural and remote areas. We also have Access Mod, which is a tool for modeling service accessibility, in particular with regard to geographic and time accessibility, which is quite important for some services, for example, emergency obstetric care, where there's a specific time limit really that you need to watch before severe complications can develop. Also, snake bite is another topic that we've been modeling recently as well. We support health sector planning and reviewing health programs with tools including Innovate to help health programs adapt their service delivery modalities for rural and remote areas. We focus on intersectoral action and transformative integrated rural development planning. And this is including through cooperation across the UN system. We've recently come out with a report on tackling inequalities in service provision in rural and remote areas. 15 different agencies, and we co-led that. And then also we're working with OECD and partners, including the European Commission, on topics such as transformative rural integrated planning and using rural proofing for that. We're working on capacity building on rural health equity and raising awareness. We've done quite a bit of work recently with WONCA, Rural WONCA, through a global webinar series for practitioners, looking at different means of addressing rural health equity. And we're also spearheading research, and this includes in the context of COVID-19, how preparedness and response plans can be adapted to better account for rural areas. And another key area that we're doing research on globally is rural proofing. Next slide, please. So first, I'd like to say we really are inspired by the pioneering work done by the European Commission in the area of rural proofing. We have learned quite a bit from that work, the guidance documents put out, the activities of their working group dedicated to this. And from a sectoral perspective, from the health sector, we are looking at its implications for example, WHO global guidance that we would give to ministries of health globally in terms of what can be done in the area of rural proofing national health policy strategies, plans, and programs. So the definition that we're using for rural proofing is how can these national health policy strategies and plans and programs better account for the needs, contexts, and opportunities of rural areas. We really see rural proofing as a governance intervention that includes both bottom-up as well as top-down interventions to ensure that these policies and programs account for rural areas. The role of rural communities and stakeholders is essential in this. And we also see that rural proofing has to take into account the differing rural context and the heterogeneity of rural populations to be effective. Next slide, please. So at global level, and if you can click through the items that will pop up now, thank you. So at global levels, we are doing research on rural proofing and what is entailed really in that. And we're discovering different hardware and software for rural proofing for health from this research. Do you mind clicking, please? Yes, perfect. So just keep going through to all, if you can click through all of them, yeah. So we're looking at things like the importance of legislation and government mandates, policy coherence, so really ensuring that that integrated rural development and health sector planning are aligned in terms of delivering on the commitments to services in rural areas. That we have champions for rural opportunities and the youth contributions that rural can provide in terms of the overarching national health service and product offer. This can be, for example, the farm to fork initiatives, looking at nutritional foodstuffs, can be looking at social farming initiatives. The importance of having data sets that map those spatial and social inequalities. We've talked about that some. Having tools and guidelines, case study collections that can support the systematization of rural proofing. That there's vertical coherence across the levels of government. So at a national level, a policy is then transferred to a provincial or a regional level, and then transferred to local level, and that there's participatory platforms that feed in the rural voice into all of these. There's capacity building, and brings together different skill sets and mindsets from decision makers from different domains, like a bit like we're doing today, in the sense that we're bringing together people working in rural development, people working in health, that not only our policies and programs are rural proof, but that also budgets are rural proofed. And this is really essential to account for the specific needs in rural areas. Next, please. There's an organizational body or committee or focal point network. And also the last one, it is that the government at different levels, national, regional, provincial, local, there's an explicit stance on for territorial and spatially balanced development. This is really essential, that it's not just seen as urbanization is inevitable, but the government is taking an explicit stance in valuing territorial balanced development. Next slide, please. So with the OECD and together with partners, including Rural Wonka and UN agencies, and also in collaboration and in conjunction with entities like the European Commission, we are advancing a Rural Proofing for Health project. It looks at bridging silos between rural development authorities and the health sector, advancing know-how, producing guidance. For example, within the next biennium, the next 2 years, we'll be producing this global guidance or toolkit on rural proofing, enhancing data. Already this past year, we've been working together on barriers assessment methods for rural and remote areas, with specific piloting in North Macedonia, and country support. So how can we bring together countries, work across countries on these topics? Next slide, please. So as was mentioned, both through the Slido and then previous presenters, really rural proofing health workforce policies is essential. Globally, WHO has guidance on this that we first developed in 2010, and then we've updated based on our work with governments around the world. It covers what can be done in the realms of education, regulation, incentives, and personal and professional support. Next slide. And our regional office for Europe, specifically through the Health and Care Workforce in Europe Time to Act strategic work, actually has a specific dedicated action area for developing strategies that attract and retain health workers in rural and remote areas. And it also, our regional office, works to foster country-to-country exchanges and study visits, looking at recruitment and retention in rural and hard-to-reach areas, competencies and education of nurses and healthcare assistants in primary care, requirements and monitoring of continual professional development and frugal innovation, low-cost digital solutions, and digital competencies for the rural health workforce. I'm going to now hand over to my colleague, Chris Brown, who's going to talk a bit more about the work done by our regional office related to rural health equity and the topics we're discussing today. Thank you.
Thank you very much for your presentation. We'll come back after on your presentation here. I invite everyone, if you want to raise your questions in the chat, and the speakers can also answer in the chat, because we'll not have the time to have, I would say, a verbal discussion here, but we can come back on any issues that have been mentioned in our breakout sessions or in the session after. So do not hesitate to address your questions in the chat, either directly to the speakers or some issues that you would like to add.
Thanks, Pascal. We still have also the colleague Chris Brown from the World Health Organization.
I know. I pass the floor to Chris. No, I am not forgetting. So Chris, you can go.
Thanks, Patricia. Thanks, Pascal, for taking the opportunity. I think it is important that we hear from people that are connected. Can I have the next slide, please? I think what we can see with this slide here, this is our recent report for the European region. This is what happens when we don't invest in rural proofing and we don't look at rural proofing for development and rural proofing for health together. And this is a report that we've just launched this year, which shows that we had 600 excess deaths in the last 3 years only in the European region, across the whole of the European region, in areas with low human development, coupled with low health systems investment. I think John mentioned this earlier. You know, you talked about we're on the precipice of disasters. Well, these are already happening because we don't have the health systems investment there. Next slide. And what that really means, and what I'd like to do is in the last few slides for WHO, show how we're developing partnerships with other sectors, with communities, with NGOs and the private sector, which are enhancing access to rural healthcare and delivering co-benefits for the other goals of the Rural Action Plan and the Rural Pact, as Alexia mentioned earlier on. Next slide. I have to say this, though, first of all. One of the problems that we have in terms of investing in rural health infrastructure, whether it be workforce, technology, systems, etc., is the fact that the health sector is seen as a drain and not an asset for development. So we've developed a tool as WHO that we are working with member states to use, which is quantifying the health sector's contribution to local cohesion, inclusion, and broader development, sustainable development goals. Here's a nice example here from North Macedonia. Theodora mentioned it earlier, who's part of the Rural Pact and Rural Proofing for Health work. We're able to show that by investing in good health systems, health workforce, strong primary health care, new models of health, linking your community hospitals to national centres of excellence, we are able to quantify that the health sector is really critical for economic regeneration, as well as delivering on its primary goal to improve people's health. And if I can just show one story, this analysis for North Macedonia was done, and we spoke to the Minister of Finance of North Macedonia 5 minutes before he went into the National Budget Committee. He looked at this because the tool we've developed is tools used by ministries of finance to quantify what sectors are important to the economy in a country. He took this into the Budgetary Commission and said, if we want to have development, rural development and cohesion, we need to invest in primary healthcare. Next slide. Another partnership that's developed recently is with the World Tourism Organization. Following COVID, many small and medium enterprises, particularly with the tourism industry, of which rural communities are dependent for their health and well-being and their livelihoods, are finding that strong health systems, public health response and emergency planning is crucial for tourism. It's crucial for preparing for emergency response, which we saw was slower in some of the rural areas because of lack of infrastructure and development. And so here's a nice example of the work that we're doing, where the other sectors and partners are working with us because they see the importance of investing in strong health systems. And the outcomes of this are inward investment in health infrastructure, making that health infrastructure free, high quality for local people and not just for tourists. And within that, improving prevention, diagnostics and treatment services. And at the same time, investing for the future and the resilience of health systems and the resilience of rural areas through emergency preparedness and response plans. Next slide. We've talked a lot about primary health care, but I think that with the work that WHO is doing in the European region with member states, you can see here examples from Sweden using e-health, which is bringing specialist care closer to local communities. But we're also seeing new models of integrated primary healthcare working with the social economy, welfare sectors and NGOs. And an example here is rural men's health sheds. We know that men with fewer years in education and in and out of employment, which is quite common for rural men, delay seeking help. They have present late for help, so therefore they have more problems for recovery. They don't practice prevention, don't follow up for prevention services, and generally have lower life expectancy and quality of life. Men's health sheds are bringing to local communities in rural areas in a way that's relevant for that local community, integrated health and social services. The impact of men's health sheds are an increase in health literacy, an improvement in mental health and social support, and in additionally, learning of new skills that can be used for employment and livelihood, which again is important for people's mental health and well-being. Next slide. And this is my last slide. We've talked a lot about digital, obviously, in the European region. We've just passed a new digital health action plan, 2023 to 2030, which we've heard already is about reducing barriers, improving access. But I also want to share an example here of how this is also promoting community well-being and cohesion and tackling issues of stigma. And I'm going to use the example of mental health, and this is my last example. In Portugal, we know that in Portugal, as in many other countries, the mental health of young people 18 to 30 in the last 3 years has declined, with 60% of more young people in that age range reporting low mental health, anxiety and depression. And what Portugal has done, it has worked with developers of apps for mental health for young people and young people's groups and young people themselves, particularly young people who are left out, to develop apps that enable young people to easily access in a non-stigmatizing way support for help with mental health, with where to get social support, access to their other public health basic goods and needs like housing and food. So here we see the real impact of some of these solutions in rural areas. And just to say that this was done initially in rural areas, it's been so successful, it's been taken to urban areas. Thanks very much.
Thank you very much, Chris, for your presentation, which is quite complementary with the one from your colleague about what is WHO doing in terms of health equity. It seems that the policy coherence between sectors has been supported and monitored by WHO, building capacities. Rural proofing is an important component of your activities, which also show the importance of accessing data to map the inequalities. Also, you have mentioned the engagement of people and rural communities, which was already underlined by John in the previous presentation. As well, you have mentioned the link between health and tourism, the importance of health systems, and also the importance of this digital dimension for, I would say, grasping the issues in rural areas in terms of access to health. So